placenta second part, and in which we will discuss about some anomalies of placenta and hormones of placenta. So let's start with anomalies of placenta. Normal placenta is attached to the upper uterine segment, encroaching the fundus part, and cord attached to the center of placenta. Okay, cord attached to the center of placenta. In the placenta previa, if the placenta is attached to the lower uterine segment because of any reason, maybe the upper uterine segment is not favorable for attachment, then it get attached to the lower uterine segment, and this is known as placenta previa, and partially or maybe completely there in the lower uterine segment. In 80% of the cases, it is found in the multiparous women and beyond the age of 35 years. This is a normal position of placenta in the uterus during pregnancy in the upper uterine segment, and in the lower uterine segment it is placenta previa. Now the battledore placenta. When umbilical cord is attached to the placental margin, it gives a resemblance like a badminton, which is previously known as battledore, so it is known as battledore placenta. Second turate placenta is a small part detached from the main parent part of the main parent placenta. When the small part is get detached from it with the connection of blood vessels, it is known as second turate placenta. Placenta sporia is a small part detaches from the main placenta, but in this there is no connection with the parent part, not connected by the vessels. Placenta bilobate, when the placenta is equally divided into two equal parts, and here it is connected with the blood vessels. So note the word connected. Only in this placenta sporia, it is not there is no connection between the parent part and the detached part, while in the second turate placenta and placenta bilobata there is connection. These three can lead to postpartum hemorrhage because the remnant part remains, if the remnant part remains within the uterus after, even after the removal of placenta, this remaining cotyledon part can lead to PPH. This is a battledore placenta, this is a battledore, and this is shuttlecock. This is used previously to play badminton like game, and this is a battledore placenta in which the placenta is attached to the margin. Okay, margin of placenta. The umbilical cord is attached to the margin of placenta. Here also the at the margin of placenta, the umbilical cord is attached, and this is known as battledore placenta. Now the we have discussed all the three. When the fetal side of placenta is smaller than maternal side of placenta, it is known as extracorporeal placenta. So fetal part is smaller than the maternal side of placenta. Normally we have seen that fetal surface is 4/5 of the placenta, and maternal surface forms only 1/5 of placenta. But here, when the fetal side is more smaller than the maternal side, this is known as extracorporeal placenta. There is a very big disadvantage of this type of anomaly, as the nutrient supply will get hampered, and the fetus growth uh, is remain paused, or you can say it's remain stopped. The fetal growth is not there. IGR may be IUDs intrauterine that can be there, and circummarginate placenta, when the chorionic membranes insert inward from the margin of placental edge. There are two things: circummarginate and circumvallate placenta. In the circumvallate, the margin gets rolled up upon itself, and this leads to a thickened ridge, and it is a thickened and rolled up, and it is not smooth. While in circummarginate, it is smooth. Maternal side surrounds the fetal side smoothly in circummarginate, while it is not smooth. It is a very rough and a thick ridge like, or a valve like, you can see area is present, okay, in the circumvallate. So vallate is valve, and in the marginate it is a smooth. Filamentous insertion of placenta, you have heard it previously in the umbilical cord section. Cord is attached to the membrane, not it is attached to the membrane, and this is a defect here, so it will lead to vesa previa, and there is more loss from the fetal blood vessels and can lead to death of the fetal death even. Here you can see this diagram: thickened ridge is circumvallate placenta. The valve-like thickness is present here. This is known as circumvallate placenta. And placental variations, filamentous insertion where cord is attached to the membranes. So, second turiate lobe in which there is connection with the blood vessels. Circumvallate, okay, circummarginate, battledore and marginal insertion of placenta, and this is bilobeta. Placenta bilobeta, okay. This is circummarginate placenta. Circummarginate, unlike circumvallate, circummarginate is a smooth, and you can see smooth, and circumvallate is a thick ridge-like. Okay, it is a thick ridge-like. So continuing video with hormones of placenta. Placental hormones are of variety types like HCG, HCS, also known as HPL, human chorionic somatotropin, or placental lactogen. This is the same thing, HCH or either HPL. And other hormones, chorionic adrenocorticotropin, chorionic thyrotropin, relaxin, parathyroid hormone related peptide, and this is human growth hormone variant, estrogen, progesterone, and some hypothalamic like releasing hormones, GnRH, CRH, corticotropin releasing hormone, CTRH, and GHRH, placental peptide hormones, neuropeptide inhibin and activin. ANP inhibin is used in variety of tests. In the quadruple test, even inhibin A is used. So we'll not discuss all of the hormones here. We'll discuss the main important hormones in this lecture. Hormones of placenta. First of all, we'll discuss the progesterone. Progesterone are from the two main sources in pregnancy, mainly from the corpus luteum of pregnancy and the placenta. Till 10th week, from the 8th to 10th week, it is corpus luteum of pregnancy which is the source of placenta. But after 10th week, the main source for the placenta is a placenta for progesterone. Okay, so corpus luteum of pregnancy lifespan is just 10 to 12 weeks. Thus after 10 weeks, the power for production of progesterone is taken by placenta. Which hormone maintains corpus luteum of pregnancy? It is HCG, which maintains the CLP, okay, and the precursor of progesterone is maternal LDL. It is maternal LDL. This is important. Maternal LDL is important for production of progesterone and functions smooth muscle relaxant. It is a smooth muscle relaxant with having the two main reactions, decidual reactions and Ariostellar reactions. So, what is decidual reaction? When the endometrium is converting into decidua, this is a decidual reaction seen in the normal intrauterine pregnancy and also in the ectopic pregnancy. Ectopic pregnancy, when the pregnancy is not there, and implantation is of the placenta of the fetus is not there in the uterus, it is rather than in the fallopian tube. It is in the fallopian tube there, not in the uterus, or maybe some other sites in the ovaries or abdominal ostium. And Ariostellar reaction is characterized by enlarged glands seen in endometrium with abundant cytoplasm and hobnail nucleus. So, Ariostellar reaction is seen in intrauterine ectopic pregnancy and also in the molar pregnancy, in which there is abundant cytoplasm and hobnail nucleus is there in the endometrium. In the patients of ectopic pregnancy, the progesterone is present but in very less amount, and the decidua is shed in form of decidual cast made up of decidual vera, which is a fused decidua capsularis and parietalis. So, endometrial sloughing in ectopic gestation is due to fall in the progesterone and beta HCG levels. Thus, the endometrial growth is not maintained in the ectopic pregnancy. Now, estrogen. Using maternal precursors, placenta cannot synthesize estrogen, as progesterone is synthesized by maternal HDL, but estrogen cannot be synthesized using the maternal precursors. So it is dependent on the fetus for synthesis of estrogen. Now, the fetal adrenal gland stimulated by ACTH releases DHEA sulfate. Okay, this DHEA is dehydroepiandrosterone sulfate, which is utilized by placenta to synthesize estrogen. Initiation of labor is what is needed for initiation of labor. This is fetal ACTH. So fetal ACTH is very important for initiation of labor, which is absent or very less amount in anencephaly fetus. So there is no initiation of labor. Maybe baby goes to postterm, and then we discover that there is anencephaly. Okay, so most common form of estrogen during pregnancy is estradiol, which is E2, diol di, that is E2, and a more specific form of estrogen during pregnancy is E3. Okay, the most common form is E2, but most specific, which suggests that it is a pregnancy, is estriol. Triol is 3, E3. HCG is a glycoprotein hormone which has two subunits, alpha and beta. Alpha 1 is similar to LH, FSH, and TSH, while beta subunit is specific subunit which is specific for HCG. As alpha subunit is having resemblance with LH, FSH, and TSH, you can know that in the hyperemesis gravidarum, when the HCG level is more, it stimulates the TSH. So there is some relation between TSH and HCG there in the hyperemesis gravidarum. We'll learn more about it in the more in some other video. Okay, so most similar to LH. It is most similar to LH, and the only difference of 8 amino acids means that only because of 8 amino acids the LH and HCG are different. Now in the first trimester, you can see that in the first trimester the hormone level HCG increases for the first 3 months, and then it decreases and takes a plateau phase, and the progesterone and estrogen were increasing continuously throughout the pregnancy period, and more it is more high, and at the peak on 8th month or around 7th to 8th month. Okay, so HCG is a glycoprotein which is similar to LHFSH and TSH, and a beta subunit is a specific subunit for HCG. It is most similar to LH with a difference only of 8 amino acids. This hormone has a highest carbohydrate content. This is the highest carbohydrate content, and it half-life is 24 to 48 hours, and doubling time of HCG is on by 48 hours is more than equal to 66%, which is increasing in the intrauterine pregnancy. But if you will check out this doubling time and of HCG in the ectopic pregnancy, you will get to know that it increases, but it is not more than 66%. It will always remain less than 66%. And even in abortions, the HCG level declines when you are going for a doubling time of HCG. You will definitely get less HCG. So this HCG is important to differentiate between abortions, ectopic, and a normal intrauterine pregnancy also. It is synthesized by syncytial trophoblast and can be detected in the serum as early as 8th day after fertilization, that is day 22 of the cycle, and 5 to 6 days before a missed period. 14th day ovulation and fertilization may be occur, and at the 28th day missed period. Okay, HCG critical titer on transvaginal sonography is 1500 international unit per liter, while on the transabdominal sonography it is 6500 international unit per liter, more than 5000. So on the transabdominal scan you will get more than 5000, while on the transvaginal scan you will get it more than 1500 international unit in the intrauterine pregnancy. Level of HCG is maximum between 8 to 10th week. You can see here this peak level at 8 to 10th week, then it get declined till the 16th week, and the minimum at the 16th week. It decreases at 70 days. HCG disappear from blood In the normal pregnancy, abortion and partial mole and complete mole. So in normal pregnancy, it disappears from blood on first to second week and in the abortion after 3 to or 2 to 4 weeks, in the partial mole after 7 week and in the complete mole after 9 week. Okay, so it disappears from the blood. Now function of HCG and HPL. What is HPL? HPL is a single polypeptide chain. I have missed the slide here, but I will discuss with you that HPL is a single polypeptide chain. Okay, it is a single polypeptide chain, and HPL is also known as HCH, that is human chorionic somatotropin, and its half life is 10 to 30 minutes. It is steadily increases throughout the pregnancy, and it is maximum at 36 weeks of pregnancy. It is maximum at that time, and at the by the term, the production of HPL is 1 gram per day. It's a 1 gram per day. Okay, it's 1 gram per day, and it is synthesized from syncytial trophoblast, and it can be detected in serum at 3 weeks after fertilization. So 3 weeks after fertilization, it is detected in the serum, detected in serum after 3 weeks of fertilization. So it is also known as HCS, and its half life is 10 to 30 minutes only, and maximum at a 36 week of pregnancy, as it increases steadily throughout the pregnancy, and is 1 gram per day. At a term, its production amount is 1 gram per day, and at the 3 weeks after fertilization, it is detected in the serum, and nothing else left more important for this, and it is synthesized by syncytial trophoblast. This is important point. And the most sensitive test to detect HCG in the blood is fluorescent immunoassay, and more than the radioimmunoassay. This is important point. Note this, that fluorescent immunoassay is more and more important point than radioimmunoassay for detection of HCG. Now coming to the differences of the HCG and HPL, similar HCG is similar to LH. It maintains the CPL of pregnancy. Okay, first stimulus to Leydig cells is testosterone. That means कि HCG gives stimulus to Leydig cells. First stimulus to Leydig cells, which helps in the production of testosterone. It prevents the resection of fetus. This is very important point, that HCG prevents the resection of fetus, and triple test of Down syndrome, HCG is considered. Like in the triple test, we have three things: alpha fetoprotein, HCG, unconjugated estrogen, which is E3 estriol, and in the quadruple test, one more thing, inhibin A is there, then it is known as quadruple test or quad test. Although hormones level decrease in the triple test in the Down syndrome, except HCG, which is increasing. Now, HPL conserves mother glucose. Okay, and it is important for insulin resistance in pregnancy, is there due to HPL. So insulin resistance in pregnancy is due to HPL at the 24 to 28 weeks of pregnancy, and lipolysis is also carried out by HPL. Now relaxin, the placental protein hormone, relaxin, its origin in pregnancies from decidua, that is endometrium layer, decidua, placenta, and corpus luteum. Relaxation of myometrium and quiescence, it is a function of this, and it also increases the GFR, and postpartum regulation of extracellular matrix degradation is done by relaxin. So it is basically a hormone for relaxation, thus increases GFR, blood flow towards the kidney, and postpartum regulation of extracellular matrix degradation. Okay, here is the placental hormone level throughout the pregnancy. You can appreciate this, that progesterone is increasing throughout the pregnancy and is maximum by the 7th 8th month of the pregnancy. Okay, here in the 7th 8th month. And HPL, this is HPL is maximum by 36 weeks of pregnancy, so you can appreciate this. And estradiol is at a constant, but it is increasing. Actually estrogen also increases, while HCG is maximum here only, and then it get decline